Hello, my name is Susan Steele. I'm the founder of Skin of Steel, a Chicago-based not-for-profit organization devoted to melanoma awareness and research. On June 4th, 2011, prior to the American Society of Clinical Oncology's national conference, we were able to host 3 melanoma specialists who came to discuss the development of the first national melanoma tissue repository. The following segment is the highlights of that briefing. Partnering with Skin of Steel on this important briefing was AIM at Melanoma, a San Francisco-based patient advocacy organization. I'd like to now introduce Valerie Guild, the founder of that organization.
The National Melanoma Tissue Repository is a project that has been waiting to happen for 40 years. The lack of primary tissue, that mole or lesion on your skin where melanoma begins, has hampered research efforts in preventing, diagnosing, and treating melanoma. We hope that after watching this video, you will agree with us that this is a project whose time has come. This tissue repository is a joint effort of our 4 collaborators, 3 of whom are here today. Dr. Eisen Morogi, who could not attend, is at the Walter Reed Army Research Center and leads their clinical trial program. Dr. Sancy Leachman leads the melanoma program at the Huntsman Cancer Institute and is one of the leading epidemiologists in the field of melanoma, particularly familial melanoma. Dr. Mohammed Kashani-Sabet leads the melanoma program at the California Pacific Medical Center and has made breakthrough efforts in the area of melanoma biomarkers. Dr. John Kirkwood, who leads the melanoma program at the University of Pittsburgh Cancer Institute, has been a leading international melanoma researcher for the last 35 years. We hope that after hearing these experts, you will understand the critical need for a national melanoma tissue repository.
Melanoma is one of the most genetic of cancers, so that if you have a family member who has had a melanoma, that automatically doubles your chance of getting a melanoma relative to somebody who looks just exactly like you, has had exactly the same experiences as you. Just the fact that you're sharing genetic material with that person who's had the melanoma makes you more vulnerable to that disease. And we're trying to understand and get at the root of how that happens. And one of the elements of understanding that is to look at the DNA in the blood, right? But the problem is that that gives you incomplete information. You really do not understand what's happened to that mole that's changed into a melanoma, or to that normal melanocyte that gives you pigment that changes to melanoma. You don't understand what the difference between that and the germline is if you don't have it to study, if you don't have that material itself to study. And so having access to the full complement of the genetic material in ways that can be studied not just at the DNA level, but at the RNA level, as Val mentioned, is very important, as well as potentially having some of that material, when it's a large enough lesion, to culture. And so what we would like to be able to do, my grand vision, so to speak, is that ultimately we won't need either of these 2 guys at all, because we're going to be able to identify the people who are at risk, right? And get them screened and get them evaluated regularly, and know how to even potentially give them what we call chemo prevention agents, to be able to reduce the number of people that ever have to go through the problem in the first place to as small of a number as possible.
My research is very much selfishly focused on the things that we don't understand in our patient population, and the frustrations that I have on a daily basis. And after the patient has already been diagnosed with melanoma, they know they have melanoma. So the key is for them, is it going to spread? You know, am I going to die of my disease or not? So we need to really understand who's at risk of the progression of their disease and who's probably cured. And maybe we don't have to worry about them in terms of the spread of their disease. And so when we first started, we looked at a lot of histological factors, things that pathologists can code by just looking at the slide. And we have also been blessed that we had one of the top pathologists in melanoma, who was my mentor, and he recorded a bunch of things that nobody ever thought of and nobody ever cared about, 30 things. And you know, first when I started my research, we actually learned that some of the things that he was recording faithfully, hoping that someday somebody would kind of study these things, and I was lucky enough to be the person to do that, we would identify some new markers. And we did histologically, and we think that they're more powerful and they help us explain what happens in some certain patients in melanoma. But it became very clear after about 5 years or so of doing this that we'd really reached the limits of what kind of classical pathology can tell us at the end of the day. And we had to go to the different level. We had to go to the molecular level. And when we started, we really didn't have any markers of melanoma aggressiveness, you know, that we used. And we still really don't have any that we use on a daily basis in our practice. So again, how thick is the melanoma? That really is what we base most of our decisions on, which is really, you know, pretty rudimentary at the end of the day. We learned more from these 30 patients that we did tissue on than thousands of patients that we've been doing prognostic analyses on. And so we've identified markers that we hope can be commercialized and can be available to all melanoma patients in the country and in the world. And some of these markers we've shown in our own group that they're more powerful in the prediction of death due to melanoma than whether the melanoma is spread to the lymph nodes or not. Imagine that you already had your melanoma removed, and by us looking at 3 of the genes in that melanoma, I could predict what's going to happen much better, okay, than having the lymph nodes removed. And imagine you didn't need to have that surgery just to understand what your prognosis is. So that's the potential of this research. The other thing is that, you know, John pioneered interferon treatment, and 20 years later or so, it's still hard to know who to say, this group, this person should get it, and this person should not get it because they will benefit. And we've been working together using our markers and applying it to the interferon patient population, and we have some hints that maybe you can identify this group if it's in the lymph nodes and they have our markers expressed in a certain way. This is the group that really benefits, and this other group doesn't benefit. So we could tell somebody, you don't really, you won't benefit from this toxic treatment. So you really should go and get into a clinical trial and try something else. And the other group say, you actually are in the group that could benefit. So I would really recommend it for you.
The message of that is that interferon, interleukin-2, ipilimumab work each in a minority of patients. 10, 15, 20, if we're lucky, 30% of patients. We need to know the biomarkers. And for IPI, we still don't know the biomarkers that predict who will benefit. We have some very strong clues, but I think this is the reason why it's critical to have a bank. So you say you have hundreds of millions of dollars of federal money for the cooperative groups. I worked as the chairman of the Melanoma Committee of the Eastern Cooperative Group, the oldest and longest in place of the national cooperative groups. We get money to do trials in patients. We get money for data managers to collect the data from trials. We do not get money to bank the tissues. How stupid. Basically, we would have advanced this field dramatically more rapidly. But the monies for Cancer Treatment Evaluation Program, CTEP, which is the NCI organ that funds the work that we do, amazing, doesn't allow for the banking of tissues. It prepares the treatment end of the thing and says to Kirkwood and Kashani-Sabet and others, go out and find your money for the banking and the research that will allow us to know who to use these treatments in after the fact. Now, we've been very successful at that over the years, or relatively successful, but we need banking now to come first. Banking is the first priority. The banking is the way in which, if we had it up front, not just several centers that we represent, but an international consortium that Val and I have worked with and Sancy to put together, would be able, at a worldwide level, to make this very big difference.